Question 1. A 45-year-old male patient presents with a history of recurrent chest pain, shortness of breath, and fatigue. Upon examination, he exhibits elevated blood pressure and an irregular heartbeat. An electrocardiogram shows signs of atrial fibrillation. After conducting a full cardiac evaluation, including an echocardiogram, the patient is diagnosed with heart failure with preserved ejection fraction (HFpEF). Given the diagnosis, which of the following is the most likely contributing factor to the patient's condition? A. Hypothyroidism. B. Coronary artery disease. C. Obesity. D. Acute myocardial infarction. Answer C. Obesity. Explanation: heart failure with preserved ejection fraction (HFpEF) is a condition commonly seen in patients with obesity, hypertension, and diabetes. The pathophysiology involves increased left ventricular stiffness, leading to impaired diastolic function. Obesity contributes to the increased workload on the heart and worsens the systemic inflammation seen in HFpEF. Although coronary artery disease and acute myocardial infarction may lead to heart failure, they are more commonly associated with reduced ejection fraction (HFrEF). Hypothyroidism can exacerbate heart failure symptoms, but is not the primary cause of HFpEF in this patient. Question 2. Mr. Harris, a 60-year-old male, presents with progressive weakness, weight loss, and difficulty swallowing. His family reports that he has experienced a significant decrease in appetite and has become increasingly lethargic. On physical examination, the physician notes the presence of a palpable mass in the neck. A biopsy reveals squamous cell carcinoma. Based on the patient's symptoms and the biopsy result, what should be the next step in managing Mr. Harris' condition? A. Begin chemotherapy immediately. B. Referral for radiation therapy. C. Perform a CANI of the chest, abdomen, and pelvis. D. Initiate immunotherapy. Answer C. Perform a CANI of the chest, abdomen, and pelvis. The explanation: squamous cell carcinoma of the head and neck often presents with non-specific symptoms such as weight loss, dysphagia, and lymphadenopathy. The next crucial step is to assess the extent of disease spread using imaging such as CT scans, which can evaluate from metastases to the chest, abdomen, or pelvis. This helps determine the appropriate treatment plan, whether it be chemotherapy or radiation therapy. Immediate chemotherapy without proper staging may lead to inappropriate management. Similarly, radiation therapy or immunotherapy would only be appropriate after determining the extent of the disease. Question 3, scenario-based. Dr. Sanders is treating a 50-year-old female patient with type 2 diabetes mellitus who presents with complaints of increased thirst, frequent urination, and a blood sugar level of 400 mmHg. The patient has been non-compliant with a prescribed insulin regimen and is experiencing signs of diabetic ketoacidosis (DKA), including fruity-smelling breath and confusion. What is the appropriate initial management step for Dr. Sanders to take in this situation? A. Administer insulin intravenously and provide fluids to rehydrate the patient. B. Start oral hypoglycemic agents to low blood glucose. C. Begin immediate dialysis to manage electrolyte imbalances. D. Monitor the patient closely and schedule a follow-up in 24 hours. Answer A. Administer insulin intravenously and provide fluids to rehydrate the patient. Explanation: diabetic ketoacidosis (DKA) is a life-threatening condition requiring immediate treatment. The primary initial management includes administering intravenous insulin to reduce the elevated blood glucose levels and fluids to rehydrate the patient, correcting electrolyte imbalances such as potassium. Oral hypoglycemic agents are not effective in treating acute DKA, and dialysis is not typically required unless there are severe electrolyte disturbances or renal failure. Close monitoring is crucial, but delaying treatment by scheduling follow-ups could lead to worsening of the condition. Immediate intervention with insulin and fluid replacement is the most critical step in managing DKA. Question 4. A 33-year-old male presents to the emergency department with sudden onset severe right-sided chest pain and shortness of breath. His medical history is significant for deep vein thrombus (DVT). 3 years ago, for which he was treated with anticoagulation. He reports no recent trauma, but he has been on long-distance flights over the past week. Physical examination reveals tachypnea, tachycardia, and hypoxia. Computed tomography (CT) pulmonary angiogram confirms the diagnosis of a massive pulmonary embolism (P). Given the patient's clinical presentation and history, which of the following is the most appropriate initial management? A. Administer low molecular weight heparin and admit to the hospital. B. Begin thrombolytic therapy and monitor in the intensive care unit. C. Provide supplemental oxygen and schedule follow-up in 1 week. D. Initiate oral anticoagulation and discharge home. Answer: B. Begin thrombolytic therapy and monitor in the intensive care unit. Explanation: massive pulmonary embolism can cause acute right heart strain, hypotension, and death if not rapidly managed. In cases of hemodynamically unstable P, thrombolytic therapy is indicated to rapidly dissolve the clot and improve blood flow. This patient's recent history of DVT and prolonged immobility due to long flights puts him at high risk. P. Oral anticoagulation alone would not be sufficient in life-threatening situation, and while heparin therapy is appropriate, the thrombolytic treatment is necessary to manage this severe P. Monitoring in the ICU is crucial due to the risk of complications such as bleeding. Question 5. A 60-year-old female presents with a gradual onset of progressive weakness, difficulty climbing stairs, and shoulder pain. She also reports feeling increasingly fatigued over the past few months. On physical examination, she exhibits proximal muscle weakness, a characteristic rash over the knuckles, Gottron's papules, and heliotrope rash on her eyelids. Laboratory studies show elevated creatine kinase (CK) levels, and electromyography (M) reveals evidence of myositis. Where's the most likely diagnosis and which treatment should be initiated? A. Polymyositis, initiate corticosteroids. B. Rheumatoid arthritis, initiate methotrexate. C. Systemic lupus erythematosus, initiate hydroxychloroquine. D. Dermatomyositis, initiate corticosteroids and immunosuppressive agents. Answer: D. Dermatomyositis, initiate corticosteroids and immunosuppressive agents. Explanation: the combination of proximal muscle weakness characteristic rashes, Gottron's papules, and heliotrope rash, elevated CK and M findings is suggestive of dermatomyositis. Dermatomyositis is an inflammatory myopathy that affects both the skin and muscles. Corticosteroids are the first-line treatment for the acute phase, often followed by immunosuppressive agents like methotrexate or azathioprine in more severe cases or for maintenance. Polymyositis shares some similarities, but lacks the distinctive skin findings seen in dermatomyositis. Rheumatoid arthritis primarily affects the joints, and lupus does not present with the characteristic muscle weakness and rash patterns seen in this patient. Question 6. Scenario-based. Mr. Thomas, a 70-year-old male, presents to his primary care physician with a history of progressive shortness of breath, orthopnea, and paroxysmal nocturnal dyspnea over the past month. His medical history includes chronic hypertension and coronary artery disease with a myocardial infarction 5 years ago. On examination, bilateral lower extremity edema, jugular venous distension. A third heart sounds. Chest X-ray reveals cardiomegaly and pulmonary congestion. Which of the following is the most likely cause of Mr. Thomas symptoms, and what is the next step in management? A. Acute respiratory distress syndrome, ARDS, intubate and administer oxygen. B. Congestive heart failure, initiate diuretics and ACE inhibitors. C. Pulmonary embolism, begin anticoagulation and thrombolytics. D. Chronic obstructive pulmonary disease, COPD, initiate bronchodilators. Answer: B. Congestive heart failure, initiate diuretics and ACE inhibitors. Explanation: Mr. Thomas' symptoms and clinical findings: dyspnea, orthopnea, paroxysmal nocturnal dyspnea, bilateral edema, heart sound, cardiomegaly are indicative of congestive heart failure, CHF, likely due to left-sided heart failure. The next step in management should include diuretics to manage fluid overload and ACE inhibitors to improve cardiac function and reduce mortality in heart failure patients. ARDS typically presents with acute respiratory distress and is not associated with the chronic symptoms and findings seen in CHF. Pulmonary embolism presents with acute onset of symptoms, often accompanied by hypoxia, which is not the primary issue in this patient. COPD presents with chronic respiratory symptoms, but does not explain the signs of heart failure such as edema and an S-heart sound. Question 7. A 25-year-old female presents to the clinic complaining of joint pain and a butterfly-shaped rash across her face. She also reports recent fatigue, photosensitivity, and mouth ulcers. Laboratory findings include a positive anti-nuclear antibody on a test and elevated anti-double-strand dd-DNA antibodies. Based on the patient's presentation, what is the most likely diagnosis and what initial treatment approach should be initiated? A. Rheumatoid arthritis, initiate methotrexate. B. Systemic lupus erythematosus, initiate hydroxychloroquine. C. Psoriatic arthritis, initiate biologics. D. Dermatomyositis, initiate corticosteroids. Answer B. Systemic lupus erythematosus. Initiate hydroxychloroquine. Explanation: the patient's presentation of butterfly-shaped rash, joint pain, photosensitivity, and positive on and DNA antibodies strongly suggests systemic lupus erythematosus. SLE. Hydroxychloroquine is mainstay in the treatment of SLE, especially for controlling skin manifestations and preventing flares. Rheumatoid arthritis typically present. Symmetrical joint involvement and is not associated with rash or positive anti-DAE antibodies. Psoriatic arthritis is characterized by joint pain and skin plaques, while dermatomyositis presents with specific muscle weakness and rashes such as Gottron's papules, not the butterfly-shaped facial rash seen in SLE. Question 8. A 52-year-old male with a long-standing history of type 2 diabetes mellitus presents with polyuria, polydipsia, and blurred vision. His laboratory results show blood glucose levels of 700 mDDR, and his arterial blood gas (BAG) reveals an elevated pH of 7.35, bicarbonate level of 20 microl, and a normal anion gap. Which of the following is the most likely diagnosis? A. Diabetic ketoacidosis, DKA. B. Hyperosmolar hypoglycemic state, HS. C. Lactic acidosis. D. Acute renal failure. Answer B. Hyperosmolar hypoglycemic state, HS. Explanation: hyperosmolar hypoglycemic state, HS, a medical emergency typically seen in type 2 diabetes characterized by extremely elevated blood glucose levels, polyuria, polydipsia, and dehydration. The key distinguishing factor in HHS compared to diabetic ketoacidosis (DKA) is the absence of acidosis and ketonemia. In HS, the pH typically maintained, as seen in this patient's BAG, and there is no significant elevation in ketones. DKA typically presents with metabolic acidosis and elevated anion gap and positive ketones. Lactic acidosis and acute renal failure may present with similar symptoms but would show different laboratory findings, e.g., elevated lactate levels or creatinine. Question 9. A 42-year-old woman with no significant medical history presents with a 2-week history of severe left-sided headache, nausea, and blurred vision. On physical examination, her blood pressure is 100/100 mmHg and she has papilledema on fundoscopy. Laboratory studies reveal an elevated creatinine level. A brain MRI shows no signs of mass lesions. Which of the following is the most likely diagnosis and what is the next best step in management? A. Acute migraine. Initiate triptans and antiemetics. B. Preeclampsia. Initiate magnesium sulfate and monitor blood pressure. C. Hypertensive emergency. Initiate Roman antihypertensive therapy. D. Intracranial mass. Initiate corticosteroids and refer for surgery. Answer C. Hypertensive emergency. Initiate Roman antihypertensive therapy. Explanation: this patient presents with signs of increased intracranial pressure, headache, nausea, papilledema, and evidence of severe hypertension. Given the elevated blood pressure 100/100 mmHg and renal dysfunction, the most likely diagnosis is a hypertensive emergency where target organs such as the brain and kidneys are being affected. Next step is to manage the blood pressure with intravenous antihypertensive therapy to prevent further end organ damage. Preeclampsia typically occurs in pregnancy, and an intracranial mass would typically present with focal neurological signs or an abnormal MRI, which is not present in this case. Question 10. A 28-year-old male presents with a 3-day history of fever, sore throat, and painful swallowing. On examination, his throat appears erythematous and there are enlarged tender lymph nodes in his neck. A rapid strep test is positive. What is the most appropriate treatment for this patient to prevent complications? A. Oral penicillin for 10 days. B. Intravenous ceftriaxone for 5 days. C. Symptomatic treatment with acetaminophen and fluids. D. Oral amoxicillin for 3 days. Answer A. Oral penicillin for 10 days. Explanation: this patient presents with symptoms of streptococcal pharyngitis confirmed by the positive rapid strep test. The first-line treatment for group as streptococcal pharyngitis is oral penicillin for 10 days as it effectively eradicates the bacteria and prevents complications such as rheumatic fever and peritonsillar abscess. Ceftriaxone is typically used for more severe infections or the patient is unable to tolerate oral medications. Symptomatic treatment alone is insufficient in preventing complications in streptococcal pharyngitis. Amoxicillin is also an acceptable option for treating streptococcal pharyngitis, but the 3-day duration is too short and it is not as effective as penicillin for preventing long-term complications like rheumatic fever. Question 11. A 50-year-old male presents to the emergency department with a complaint of dizziness, double vision, and difficulty swallowing. His vital signs are stable, but upon examination, he has a slight right-sided ptosis and a decreased gag reflex on the right. He also shows signs of dysarthria. OK of the brain shows no acute findings. What is the most likely diagnosis? A. Multiple sclerosis. B. Stroke affecting the brainstem. C. Myasthenia gravis. D. Guillain-Barré syndrome. Answer B. Stroke affecting the brainstem. Explanation: the patient's presentation, including right-sided ptosis, dysphagia, and dysarthria, suggests a lesion affecting the brainstem. The most likely diagnosis in this case is a stroke affecting the brainstem where the cranial nerve nuclei are located, leading to deficits in both motor and sensory functions. Multiple sclerosis is less likely given the absence of other neurological signs. Myasthenia gravis typically presents with muscle weakness that worsens with exertion, and Guillain-Barré syndrome generally involves ascending paralysis. Question 12. A 62-year-old woman with a history of type 2 diabetes mellitus presents to her physician for a routine checkup. She has been experiencing increased thirst and frequent urination over the last month. On examination, her blood pressure is 135/85 mmHg and her weight has increased by 5 kilograms in the past month. Her fasting blood glucose is 107 ndl and her HbAC is 8.5%. What is the next best step in management for this patient? A. Start insulin therapy. B. Adjust the patient's current oral medications and reinforce lifestyle modifications. C. Refer to an endocrinologist for further evaluation. D. Initiate a low-salt, low-fat diet. Answer B. Adjust the patient's current oral medications and reinforce lifestyle modifications. Explanation: the patient has poorly controlled type 2 diabetes as evidenced by the elevated fasting blood glucose and HbAC. The first step in management is to optimize the current treatment regimen. This could involve adjusting her oral medications, such as increasing the dose of metformin or adding a second-line agent like a sulfonylurea, and reinforcing lifestyle changes, including diet and exercise. Insulin therapy is typically considered when oral medications are insufficient to control blood glucose levels, and referral to an endocrinologist is usually not required unless there are complicating factors. Question 13. Mr. Thompson, a 56-year-old male, comes to the office complaining of a persistent cough, unintentional weight loss, and night sweats for the past 3 months. He has a history of smoking 1 pack of cigarettes per day for 30 years. On physical examination, he appears cachectic, and there is a dullness to percussion over his right lower lung. What is the most likely diagnosis? A. Chronic obstructive pulmonary disease, COP. B. Tuberculosis. C. Lung cancer. D. Pneumonia. Answer C. Lung cancer. Explanation: Mr. Thompson's history of smoking, along with his presentation of weight loss, night sweats, and cough, are highly suggestive of lung cancer. The dullness to percussion over the right lower lung may indicate a pleural effusion, which is commonly associated with advanced lung cancer. Tuberculosis and pneumonia could present with similar symptoms, but the patient's smoking history and the chronicity of the symptoms make lung cancer like a diagnosis. Question 14. A 35-year-old woman presents with a history of irregular menstrual cycles and excessive hair growth on her face and chest. She has a BL of 32 and states that she has gained 10 kilograms over the past year. On examination, she has mild acne and hirsutism. Her laboratory results show elevated testosterone levels. What is the most likely diagnosis? A. Polycystic ovary syndrome, PCOS. B. Cushing's syndrome. C. Hyperthyroidism. D. Primary ovarian insufficiency. Answer A. Polycystic ovary syndrome, PCOS. Explanation: the patient's symptoms of irregular menstrual cycles, weight gain, hirsutism, and elevated testosterone levels are classic signs of polycystic ovary syndrome, PICA. PCOS is often associated with insulin resistance, which contributes to weight gain and elevated levels of androgens like testosterone, leading to hirsutism and acne. Cushing's syndrome can present with weight, but it would be more likely to involve other features like purple striae and moon phases. Hyperthyroidism and primary ovarian insufficiency would present with different clinical signs. Question 15. A 22-year-old male presents with severe abdominal pain, vomiting, and bloating. He mentions that the symptoms started after consuming a large meal and have progressively worsened. On examination, his abdomen is distended and there is absent bowel sounds. A plain abdominal X-ray shows a double bubble sign. What is the most likely diagnosis? A. Acute pancreatitis. B. Small bowel obstruction. C. Gallbladder disease. D. Duodenal atresia. Answer D. Duodenal atresia. Explanation: the double bubble sign on the abdominal X-ray is characteristic of duodenal atresia, a congenital obstruction of the duodenum that presents with vomiting and abdominal distension in the neonatal or early infantile period. Although small bowel obstruction and acute pancreatitis can present with similar symptoms, the radiographic finding of two air-filled bubbles suggests duodenal atresia. Gallbladder usually presents with right upper quadrant pain and does not typically cause the radiographic findings seen here. Question 16. A 28-year-old woman presents with a butterfly-shaped rash across her nose and cheeks, along with joint pain and fatigue. She also reports sensitivity to sunlight. Her laboratory findings include a positive on a test and elevated to DNA antibodies. What is the most likely diagnosis? A. Systemic lupus erythematosus. SLE. B. Rheumatoid arthritis. C. Dermatomyositis. D. Psoriatic arthritis. Answer A. Systemic lupus erythematosus. SLE. Explanation: the patient's symptoms of a butterfly-shaped rash, joint pain, fatigue, and sun sensitivity, along with the positive on an elevated DNA antibodies, are highly suggestive of systemic lupus erythematosus. SLE. SLE is an autoimmune disease characterized by a wide range of systemic symptoms, including skin rashes, joint involvement, and positive serologies. Rheumatoid arthritis typically involves symmetrical joint pain and deformities, but lacks the characteristic skin findings. Dermatomyositis and psoriatic arthritis have different clinical features, including muscle weakness and psoriasis, respectively. Question 17. A 40-year-old male presents with sudden onset of severe right upper quadrant pain, nausea, and vomiting. He has a history of intermittent epigastric discomfort and fatty food intolerance. On examination, his abdomen is tender in the right upper quadrant and Murphy's sign is positive. His serum liver enzymes are mildly elevated. What is the most likely diagnosis? A. Acute pancreatitis. B. Gallstones with acute cholecystitis. C. Peptic ulcer disease. D. Gastroesophageal reflux disease. Jed. Answer B. Gallstones with acute cholecystitis. Explanation: the patient's presentation of right upper quadrant pain, nausea, vomiting, positive Murphy's sign, and mildly elevated liver enzymes is characteristic of acute cholecystitis, often due to gallstones. The pain is usually precipitated by fatty meals, and Murphy's sign, which involves pain upon palpation of the gallbladder during inspiration, is a classic finding. Acute pancreatitis. Peptic ulcer disease are less likely given the localized nature of the pain and the associated symptoms. GERD typically presents with heartburn and regurgitation rather than acute abdominal pain. Question 18. A 72-year-old male with a history of hypertension and hyperlipidemia presents with gradual onset of leg pain and weakness that worsens with walking and improves with rest. He also reports numbness and tingling in his legs. His pulses are absent in both lower extremities. What is the most likely diagnosis? A. Peripheral arterial disease. B. Deep vein thrombosis. C. Lumbar spinal stenosis. D. Diabetic neuropathy. Answer A. Peripheral arterial disease. Explanation: his patient's symptoms of caudation, including leg pain and weakness that worsens with walking and improves with rest, suggest peripheral arterial disease. PAD occurs due to atherosclerosis of the peripheral arteries, often in patients with hypertension and hyperlipidemia, and is characterized by intermittent caudation. The absence of pulses in the lower extremities further supports this diagnosis. Deep vein thrombosis typically presents with unilateral leg swelling and redness, while lumbar spinal stenosis presents with pain relieved by bending forward, not rest. Diabetic neuropathy is less likely given the lack of other diabetes-related symptoms. Question 19. A 30-year-old female presents with increased fatigue, weight gain, and cold intolerance over the past 6 months. On examination, she has dry skin, a puffy face, and a slow heart rate. Laboratory tests show an elevated TSH level and low Freed. What is the most likely diagnosis? A. Hypothyroidism. B. Hypothyroidism. C. Hashimoto's thyroiditis. D. Pituitary adenoma. Answer A. Hypothyroidism. Explanation: the patient's symptoms of fatigue, weight gain, cold intolerance, dry skin, and puffy face, along with an elevated TH and low free T, indicate hypothyroidism. The elevated TH is compensatory for the low thyroid hormone levels. Hashimoto's thyroiditis is a common cause of hypothyroidism, and while it is the most likely etiology in this case, the question does not provide specific information about antibodies or thyroid ultrasound findings. Hypothyroidism and pituitary adenomas typically present with different clinical features. Question 20. A 24-year-old woman presents with a 2-week history of fever, sore throat, and swollen lymph nodes. Her examination reveals a maculopapular rash, her liver function tests are elevated, and she has a positive heterophile antibody test. What is the most likely diagnosis? A. Epstein-Barr virus infection. B. Cytomegalovirus (CMV) infection. C. Streptococcal pharyngitis. D. Toxoplasmosis. Answer A. Epstein-Barr virus (EBV) infection. Explanation: the patient's symptoms of fever, sore throat, swollen lymph nodes, rash, and positive heterophile antibody test are highly suggestive of Epstein-Barr virus (EBV) infection, also known as infectious mononucleosis. EBV is characterized by these findings, and liver enzyme elevations are common. CMV infection can cause similar symptoms but is less likely to cause a positive heterophile antibody test. Streptococcal pharyngitis typically does not cause lymphadenopathy or a rash, and toxoplasmosis usually presents with different clinical features. Question 21. A 65-year-old male presents with a 3-month history of progressively worsening shortness of breath, fatigue, and a dry cough. He denies any significant weight loss or fever. On physical examination, he has bilateral fine crackles at the lung bases. His chest X-ray shows bilateral reticular opacities. A high-resolution CT scan reveals a honeycombing pattern in the lungs. What is the most likely diagnosis? A. Pulmonary fibrosis. B. Acute pneumonia. C. Chronic obstructive pulmonary disease (COP). D. Tuberculosis. Correct answer A. Pulmonary fibrosis. Explanation: the patient's symptoms of shortness of breath, fatigue, and dry cough, along with bilateral fine crackles and a honeycombing pattern on high-resolution CT, are highly indicative of pulmonary fibrosis, particularly idiopathic pulmonary fibrosis. This condition is characterized by progressive scarring of the lung tissue, which leads to the described radiographic findings. Acute pneumonia, presence with fever and productive cough, and tuberculosis would have additional features like night sweats and weight loss. COPT is less likely given the absence of a significant smoking history. Question 22. A 42-year-old woman presents to the emergency department after a fall from a height of 10 feet. She complains of severe pain in her right ankle, and on examination, her ankle is swollen, bruised, and deformed. X-ray reveals a displaced fracture of the distal fibula with some widening of the syndesmosis. What is the most appropriate next step in management? A. Apply a cast and discharge the patient. B. Immediate surgical consultation for possible open reduction and internal fixation, or if. C. Apply a splint and discharge the patient with crutches. D. Recommend rest and ice for a sprain. Answer B. Immediate surgical consultation for possible open reduction and internal fixation, or if. Explanation: the presence of a displaced fracture of the distal fibula with widening of the syndesmosis suggests a possible unstable fracture such as a high ankle sprain or a syndesmotic injury. This type of injury typically requires surgical intervention for fixation to restore the proper alignment of the bones and prevent long-term complications. Applying a cast without proper fixation or recommending rest for a sprain would not address the instability of the fracture. Immediate surgical consultation is warranted for possible open reduction and internal fixation, or if. Question 23. A 55-year-old male with a history of alcohol use disorder presents with confusion, ataxia, and ophthalmoplegia. He also has a history of poor nutrition. His physical examination shows nystagmus and a positive Romberg test. What is the most likely diagnosis? A. Wernicke's encephalopathy. B. Delirium tremens. C. Hepatic encephalopathy. D. Korsakoff syndrome. Answer A. Wernicke's encephalopathy. Explanation: the patient's history of alcohol use disorder, confusion, ataxia, ophthalmoplegia, and nystagmus is highly suggestive of Wernicke's encephalopathy, a thiamine deficiency-related condition. This condition often occurs in the context of chronic alcohol use and poor nutrition. Delirium tremens is associated with alcohol withdrawal and typically presents with severe agitation, tremors, and delirium, but without specific neurological signs seen here. Hepatic encephalopathy would be associated with liver dysfunction, and Korsakoff syndrome is a late sequela of Wernicke's encephalopathy that typically presents with memory impairment. Question 24. A 22-year-old woman presents with a history of excessive thirst, frequent urination, and unexplained weight loss. She has a family history of type 1 diabetes. Her blood glucose level is 350 mdl and her urine is positive for ketones. What is the most likely diagnosis? A. Type 1 diabetes mellitus. B. Type 2 diabetes mellitus. C. Hypothyroidism. D. Diabetic ketoacidosis. Answer A. Type 1 diabetes mellitus. Explanation: the patient's symptoms of excessive thirst, frequent urination, and unexplained weight loss, combined with blood glucose of 350 mdl and positive ketones in the urine, are classic signs of type 1 diabetes mellitus (TDM). This is an autoimmune condition in which the body attacks insulin-producing beta cells in the pancreas, leading to insulin deficiency and hypoglycemia. Diabetic ketoacidosis (DKA) is complication of TDM, not separate diagnosis, and hypothyroidism would not present with elevated glucose or ketones. Question 25. A 30-year-old man presents to the office with the complaint of painful, swollen joints in his fingers and wrists. He also mentions a recent episode of a red, raised, scaly rash on his elbows and knees. He has a family history of psoriasis. What is the most likely diagnosis? A. Rheumatoid arthritis. B. Gout. C. Psoriatic arthritis. D. Osteoarthritis. Answer C. Psoriatic arthritis. Explanation: the patient's symptoms are joint pain and swelling in the fingers and wrists, along with the history of red, raised, scaly rash on his elbows and knees, are highly suggestive of psoriatic arthritis, which is a form of inflammatory arthritis associated with psoriasis. Rheumatoid arthritis typically affects the small joints symmetrically and would not be associated with psoriasis. Gout typically presents with pain and swelling in the big toe, and osteoarthritis usually affects weight-bearing joints without systemic symptoms. Question 26. The 68-year-old woman presents with chronic lower back pain and numbness in her legs that worsens when she stands or walks. She finds relief when she sits down or leans forward. On examination, she has decreased sensation in her legs and a positive straight leg raise test. What is the most likely diagnosis? A. Lumbar disc herniation. B. Spinal stenosis. C. Multiple sclerosis. D. Vertebral fracture. Answer B. Spinal stenosis. Explanation: the patient's symptoms of leg numbness and pain that worsen with standing or walking and improve with sitting or leaning forward are characteristic of spinal stenosis. This condition involves narrowing of the spinal canal, which can compress nerves, leading to neurogenic claudication. Lumbar disc herniation can present with similar symptoms, but is usually associated with radiating leg pain, sciatica. Sclerosis typically presents with neurologic deficits in multiple areas and not localized to the lower back. Vertebral fractures are more likely to present with acute pain after trauma. Question 27. A 45-year-old woman presents with a history of fatigue, hair thinning, and cold intolerance. On examination, she has a puffy face and dry skin. Laboratory results reveal an elevated TSH level and a low free level. What is the most likely cause of her condition? A. Hashimoto's thyroiditis. B. Graves' disease. C. Pituitary adenoma. D. Thyroid cancer. Answer A. Hashimoto's thyroiditis. Explanation: the patient's symptoms of fatigue, cold intolerance, puffy face, dry skin, and laboratory findings of an elevated TH and low free are characteristic of hypothyroidism, most commonly due to Hashimoto's thyroiditis. Hashimoto's thyroiditis is an autoimmune thyroid disorder where the immune system attacks the thyroid gland, leading to its destruction. Graves' disease typically presents hypothyroidism, not hypothyroidism. Pituitary adenomas usually result in secondary hypothyroidism but would not cause high TSH. Thyroid cancer typically presents with palpable thyroid nodule and does not typically cause hypothyroidism. Question 28. A 55-year-old male presents to the clinic with a history of progressive shortness of breath, especially on exertion, and a non-productive cough. He also mentions a history of chronic smoking. Physical examination reveals a prolonged expiratory phase, wheezing, and decreased breath sounds. What is the most likely diagnosis? A. Chronic obstructive pulmonary disease, COP. B. Asthma. C. Pneumonia. D. Pulmonary embolism. Answer A. Chronic obstructive pulmonary disease, COPT. Explanation: The patient's progressive shortness of breath on exertion, non-productive cough, history of chronic smoking, and physical findings of prolonged expiratory phase, wheezing, and decreased breath sounds are all consistent with chronic obstructive pulmonary disease (COPD). COPD is most commonly caused by long-term smoking and is characterized by airflow obstruction and emphysema. Asthma would have more episodic symptoms and would typically present in younger patients. Pneumonia and pulmonary embolism would present with more acute symptoms. Question 29. A 38-year-old female presents with a complaint of progressive muscle weakness, especially in her upper arms and legs, and difficulty swallowing. On examination, she has a hoarse voice and a symmetric weakness that worsens with repetitive movements. What is the most likely diagnosis? A. Myasthenia gravis. B. Amyotrophic lateral sclerosis ALS. C. Multiple sclerosis. D. Lambert-Eaton myasthenic syndrome. Answer: A. Myasthenia gravis. Explanation: the patient's symptoms of progressive muscle weakness, especially in the arms and legs, difficulty swallowing, hoarseness, and worsening of weakness with repetitive movements are highly suggestive of myasthenia gravis. Myasthenia gravis is an autoimmune disease that affects the neuromuscular junction, leading to weakness that worsens with activity and improves with rest. Owls would present with more asymmetric weakness and fasciculations. Multiple sclerosis typically presents with more varied neurological symptoms. Lambert-Eaton syndrome is associated with cancer and presents with muscle weakness that improves with repetitive movement, but is less common than myasthenia gravis. Question 30. A 60-year-old male presents with increasing difficulty in swallowing and frequent regurgitation of food. He also reports chest pain and a sensation of food sticking in his throat. He denies weight loss or fever. On examination, he has no signs of infection. What is the most likely diagnosis? A. Achalasia. B. Gastroesophageal reflux disease (GERD). C. Esophageal cancer. D. Peptic ulcer disease. Answer: A. Achalasia. Explanation: the patient's symptoms of difficulty swallowing, dysphagia, regurgitation, chest pain, and sensation of food sticking in the throat are consistent with achalasia, disorder of the esophagus characterized by the inability of the lower esophageal sphincter to relax. This results in functional obstruction of the esophagus. GERD typically presents with heartburn and regurgitation but does not cause dysphagia to the extent C. Achalasia. Esophageal cancer and peptic ulcer disease would typically present with additional alarming signs such as weight loss, but achalasia is more likely given the absence of these signs.